Dear Chairman, dear audience, I'm glad to be here, and I'm really glad that there's still an audience here. And I'm really glad for those who are still awake. And for those who are not, I've got a question, as usual. If you've listened carefully to the impressive presentation of Dr. Obeidat, you've already heard that the overall average mortality of gastrointestinal bleeding is about 2.5 to 15%. And my question is, what do you think, what proportion of death is directly related to the gastrointestinal bleeding? It's 2 to 5, 10 to 15, or 40 to 50%. So hands on if you think it's 2 to 5%. Okay, 10 to 50. Okay, there are some still, and 40 to 50%. Okay, thanks. So actually the answer is 10 to 15%. In other words, in more than 80% of the patients are not dying because the gastrointestinal bleeding, directly the bleeding, I mean, so the uncontrollable bleeding, but some other comorbidities and some organ failures. I'm working as a gastroenterologist in one of the biggest departments, gastroenterology department here in Hungary, and we frequently meet patients who are hospitalized with gastrointestinal bleeding and taking anticoagulants at the very same time. They are treated for several reasons, and actually the question is not just how to manage these patients, how to save their lives just right there, but what to do after this. And my mission is to find the best way how the anticoagulation should resume after this gastrointestinal bleeding. For these goals, I've got 3 projects. In the first project, we are working with the already existing data. Actually, from the background of this, that we are focusing only for the direct oral anticoagulants, the so-called DOACs, because in the last 10 years, since they entered to the market, the use of these medications are increasing rapidly. It's easier for the patients and for the clinicians and for everyone. And they are thought to be are really safe medications, but still there's an average annual bleeding risk of about 3 to 4%. And there are data on what's happening if we restart the anticoagulation after the gastrointestinal bleeding. Mostly these data are coming from the other type of medications, the vitamin K antagonist, and it says, although there's data on where the rebleeding risk is still higher, the overall benefit is bigger in a longer period because the risk of thromboembolic complications and mortality is it's less in these populations. But our aim is to determine the safety and efficacy only for the direct oral anticoagulants patients. So we formed our clinical questions, and the population is patients who are taking DOACs while they suffer the gastrointestinal bleeding. The intervention is if we resume the anticoagulation, the DOACs. The controls are if we do not resume the therapy, so we permanently interrupt the therapy. And we observe the mortality, thromboembolic events, and rebleeding. And our hypothesis is that resuming the DOAC therapy is significantly lower the mortality and thromboembolic complications. So we performed our systematic review, but only found at the end 3 eligible articles, and all of these are retrospective cohort studies, so not the highest evidence. Our first results, that you can see here, is the risk of recurrent gastrointestinal bleeding between these 2 groups. And the odds ratio is 1.09, not the hazard ratio, sorry, I wrote that, but 1.09 with a confidence interval cutting the line of null effect. And what actually that means, that in our meta-analytic calculations, we could not find any association between the resumption of therapy and the rebleeding risk. And in the other 2 outcomes, the thromboembolic complications as all-cause mortality, unfortunately, we do not have sufficient evidence to make the meta-analytic calculations. So I represent here the results of the two study, what we've got, and they also did not find any statistical associations in these 2 groups. So why is it important, actually? We are focusing only on DOACs, and if we consider that the pharmacological feeders of the anticoagulations are different, then there's the space and there's the reason why we should do these examinations. But still, we've got a lot of limitations, just like the low quality data, what we've got. And as we did not find any association between the rebleeding and the DOACs resumption, as I already mentioned, and we don't have sufficient evidence for the efficacy outcomes. But still, there's an implication. First of all, we have to handle with criticisms this data because there are differences between the studies as well. It was also not the same definitions of rebleeding or therapy resumption data, and also the follow-up period. So these studies were not the best. But with these results, we can highlight that not every patient who get their medication back will suffer rebleeding at all. And with this data, we can mitigate the general fear of anticoagulation use after the gastrointestinal bleeding, and we can decrease the inappropriately high therapy withdrawal rate. And implications for research, we highlighted not just highlighted that we need a randomized controlled trials, but in my work we really went through all the pitfalls that we have to consider if we really want to make a randomized controlled trial. Actually, the manuscript is under review in the American Journal of Gastroenterology, and until we are waiting for the rejection, we had to do something. Oh, Balint, you are okay. So anyway, right now we see that the evidence is really low in this topic. And, but if we accept that the previous study shows that, that there is a benefit if we reintroduce the therapy, although they were vitamin K antagonists, the really question is how to reintroduce this medication and when. So we are working on protocol of non-inferiority randomized controlled trials, the so-called time to study, where we want to determine the earliest time for safe therapy withdrawal, resumption, sorry. So our hypothesis is that the early resumption is not inferior to late resumptions. Early resumptions in our protocol will be 3 days, reintroduction of the therapy 3 days after the index endoscopy, and the delayed resumption will be 7 days. And we only want to include adult patients who were taking DOACs prior to the index upper gastrointestinal bleeding. And this bleeding source has to be proved by a special endoscopist, and if necessary, has to be treated with a proper endoscopist intervention. And we want to exclude all those patients who are really high risk, who has really high risk for rebleeding or really high risk for thromboembolic complications and do not have the time for the 3 days until we start the anticoagulant medications. And after allocating randomly these patients to the 2 arms, the first arm, as I mentioned, will get their anticoagulant medications on the 3rd day from the endoscopic intervention. We chose day 3 because there's some data, the highest risk for rebleedings in the very first 72 hours after the first bleeding. And the other arm will be 7 days after the endoscopy. It's because the guidelines suggest to do so at least on the day 7 to restart their anticoagulation. And we will observe rebleeding as the first, as the primary outcome, and stroke and other thromboembolic complications as the secondary outcomes. I'm still writing the protocol, and hopefully we'll finish it in 2 weeks. And until that, we've got some time, because a study just to write a protocol, it's okay, it lasts for some months, but this study will last for ages. So we have to do something, because we really do not have enough data on this project. And we are working with the translational medicine registries the so-called Gastrointestinal Bleeding Registry. It's started their work in 2019 and already involved more than 1,000 patients in 2 centrums, in Pécs and in Székesfehérvár. And they are getting data from patients prospectively, but it's an observational registry. But hopefully from September we can start in our department as well, in the military hospital here in Budapest as well. And in this registry, we get information from patients from the very beginning, so after the gastrointestinal bleeding, so admissions to the emergency, through their treatments in the managements in the gastroenterologist department, and until the discharge. And hopefully we will manage to get some informations after after the hospital discharge. So with these 3 projects, I really want to focus on how to resume the medications after these gastrointestinal bleeding episodes. Thank you for your attention, and I'm happy to answer for your questions.
Thank you, Dani, for the excellent presentation. My question would be regarding the second project. What would be regarding the dosage? What would be the standardization for that? And also, do you think there will be a difference? I'm not a doctor, so I'm just asking if the indication for DOAC initially would make a difference to the results. Do you think there could be anything like that?
Well, for all of the DOACs, there are 2 dosage, higher and a lower dosage, mostly because they are depending from the renal function. So we have to handle this problem as well. But in the exclusions criteria, we want to exclude all those patients who are really the renal insufficiency. So the creatinine clearance is lower than 30 once. The second question was regarding to whether there's a difference why they get the medication.
Yes, the initial
indication. Well, actually, DOACs are not allowed to give in mechanical heart valve patients, and these patients who already exclude because they do not have the time for 3 days without any medications, we will exclude this. Otherwise, I don't think so. I mean, the rebleeding is a really complex thing. And not just the anticoagulations, it's also depending what kind of bleeding source you had. What was the medical treatment for this? There are some other risk factors, many risk factors we have to really consider. So it's quite complex, and that's why it's really hard to manage it in a good way, this randomized control trial.
Good luck to the project.
Thanks.
Thank you, Dani, for the nice presentation. My question is also about the protocol. You said it's going to be a non-inferiority trial.
Yes,
Have you considered a cutoff for the non-inferiority? Like, what should be the difference in the primary outcome incidence rates between the groups for the non-inferiority?
Actually, we are discussing it for the statisticians for, I don't know how many times, but we are not ready yet. Hopefully we will manage it. But yes, that's it. It's a good question. If you get some ideas, just tell me.